So we will now move on to today's clinical topic. And our speaker today is Dr. Eugene Lee. Dr. Lee earned his dental degree from the University of Michigan and then did a 2-year residency at the Veterans Affairs Medical Center in New York. Then he completed his specialty training in prosthodontics at the VA in West LA. And he's currently our Glidewell Fellow in residence here at our clinic. He has extensive experience in implant surgery and prosthodontics, and you are going to enjoy his lecture today on the overdenture option. And he's going to take us through an overview of this important treatment option. And Dr. Lee, it is all yours.
Thanks everyone for joining us today. The topic today is the overdenture option, as Dr. Park has mentioned. As full arch fixed prostheses gain a lot of popularity these days, I wanted to recognize and highlight the value of overdentures, and it is still indicated in today's dentistry. As we have limited amount of time, we will focus mainly on the implant locator retained overdenture, which I think are much more common treatments that are being rendered these days. We will talk about when we want to prescribe overdentures, how we want to treatment plan them. I will show you a quick example of a case. Then finally, some of the maintenance factors you may want to consider. Before we begin, you may have heard the term implant-assisted and implant-supported dentures, and I wanted to clarify the definition before we continue. Implant-assisted prostheses share the occlusal force between implants and soft tissue, while implant-supported prostheses have all of its occlusal forces loaded on implants. And sometimes, as you can see, even when you have locator overdentures, like on the bottom, due to how the implants are spread out, oftentimes all the occlusal force is likely to be on the implants only. And we will talk about how that can impact your prognosis. The first indication of doing overdenture is if your patient has extremely high smile line and you can't really hide the transition line here. And here is a particular treatment after extraction of the maxillary anterior teeth. You can see the residual ridge at patient's high smile line. So with fixed prostheses, this would be a transition line, which is the prosthetic tissue junction. You want to obviously hide this if you were to do fixed prosthesis. And in this particular case, removing this bone would do a fix would mean that there would not be enough bone height to place even the shortest implants in premaxilla. If you plan incorrectly in terms of high smile line and where the transition line is, this is the potential outcome. Where you have the aesthetic failure, you certainly want to avoid this kind of situation here. So flanges. The flanges are something that patients generally don't like, but really they have many important functions in prostheses. It gives a retention by sealing the periphery. It gives lateral stability. It hides a tissue junction or transition line. And finally, it also provides aesthetic bifacial and lip support. And what do I mean by that? An aesthetic bifacial lip support that we often don't think about. Take this patient, for example. You can see how on the left, a set of complete denture was able to transform him to the right, where you no longer have the prominent nasolabial fold and lack of lip support and very thin lips, which is not certainly ideal. Here's a second patient. So in a profile view on the left, you can see how this lady has what we call witch's chin right here. And you can a very prominent nasolabial fold. And you can appreciate how much better the facial aesthetic is if with a proper set of dentures that she received. Another indication of doing overdenture is if your maxilla and your mandible has arch discrepancy. It can be a skeletal discrepancy, but it can also be because of alveolar ridge resorption. And in a case like this, now you have a disconnect between where the maxillary anterior teeth needs to be versus where the ridge is. And the anterior teeth position is determined by aesthetic and function, such as phonetic and occlusion. So if you attempt to treat this patient with fixed prostheses, there is a very high chance that you may end up in a big ledge or concavity where the food can get impacted, which is not ideal. So then why do we not have flanges fixed? So people often try to solve this problem with putting a flange on fixed prostheses. But this creates a lot of problem, which you can see here. The concavity created by the flange will trap food and patients can't really clean them. The standard of care for any dental prosthesis is that it must be cleansable. So if you're providing a prosthesis that is not removable, it needs to meet all the criteria, which the patient is able to clean as well. Another indication that I think about is even if you have a properly designed prosthesis, if the patient can't take care of it or has a caretaker who can help them, it may be better to have a removable prosthesis. So manual dexterity for proper hygiene is essential for fixed prostheses as well. The next, in terms of the cost, a lot is changing in the recent years with the advancement of technology. The implant fixed prostheses is certainly getting cheaper and closing the cost gap between the fixed and implant bar overdenture. However, the implant located overdenture is still much cheaper than the fixed prostheses. So if a cost is part of the factors that you are considering, then you may want to consider this as well. Another indication to do removable would be if the patient has a severe parafunctional habits. Some of the obvious signs would be worn remaining dentition or prostheses, but also you should evaluate if the patient has hypertrophic masseter, like the patient on the right, or a sign of an antigonial notch on the panoramic radiograph. And what I mean by that is this concavity on the panoramic at the angle of your mandible. So antigonial notch is developed since there's where the masseter is attached to, and strong masseter will create the notch as shown on the panoramic. So if you see these signs, you can make an educated guess that the patient may have a parafunctional habit and or have a strong bite strength, which can compromise your future fixed prostheses. And certainly fixing your fixed prostheses is going to be much challenging than fixing your removable one. So if you ignore these indications and warning signs, then this is potential what can happen. At 4:30 p.m., you have a patient coming in saying that we have an emergency patient. It's not to say that removable won't have incidence of fracture ever, but it would happen in much less prevalence than fixed prostheses, and is a way to mitigate potential problem like this. And if something were to break, I think we can all agree repairing or replacing fixed prostheses would be much more involved process for both parties. Now that we talked about when you may want to consider implant overdenture, let's talk about treatment planning for one. And designing a resilient attachment overdenture follows the denture principle pretty closely. We will talk about where the ideal location of the implants should be. Lastly, we will briefly discuss implant bar supported overdentures and some considerations as well. So denture principles, when you're fabricating an overdenture, you consider the same principle as denture fabrication in terms of flanges and having adequate support. For maxilla, we have tuberosities and hard palate. For mandible, we have retromolar pad and buccal shelf. Considering these areas will help reduce the occlusal load on your implants, which will minimize the risk of overloading them. Again, the primary support areas for maxilla is hard palate and maxillary tuberosity. And for mandible, it'd be retromolar pad and buccal shelf. So if you don't have inadequate support and don't have inadequate extension of the flanges, it'll lead to inadequate, eventually cause excessive crestal ridge resorption, as those areas are the primary support areas that don't seem to resorb and helps retain those other ridges that you want to maintain for years to come. We are going to talk about implant positions for overdentures. For overdentures, implants serve as a way to provide additional retention, and you want to avoid putting a lot of forces on the implants. It's just better for implant health over time, which means you want to have implants away from the supported areas. So you want to have implants placed on for maxilla 5, 7, 10, 12. And I always encourage dentists to keep the palate on for additional support. But if you decide to remove the palate, having additional implants on site 3 and 14 could share the load and be helpful to the implant health as well. For mandible, the implant should be placed in the anterior portion, since the retromolar pad and buccal shelf are the primary support areas. You can either place 2 unilateral incisor positions, which are red, or you can place 3 at canine and midline position. Having 3 implants in the anterior can help minimize the anterior tipping of the denture, and this is especially true if your incisor of the lower denture are more anterior to the implant locator abutments. When we consider full arch prostheses, numerous papers found that locator retained implant-assisted overdentures are the most cost-effective treatment for patients to get their function and quality of life back. Next, we'll talk about the restorative space consideration for locator overdentures. The minimum space you need is 9 millimeters. This is determined by the biology and material thickness that is required to give adequate strength. However, you see here that the denture tooth is only 3 millimeters, and it is highly unlikely that you will have a denture tooth that is only 3 millimeters tall, unless you're in a posterior area. So you have to measure what is the likelihood of the denture tooth length in a certain area and add that to the appropriate space requirement. Here's the restorative space consideration for implant bar overdenture. Now you have a hygiene space under the bar, and the bar thickness is to account for, and tooth is indicated to be only 3 millimeters here on this paper as well. So consider that the total height requirement should be about more than 18 to 19 in my opinion, but based on this paper, the minimum normal will be 14. But I would say, considering the tooth length, I would say about 18 to 19 millimeter would be appropriate. So if you don't consider those factors, most often the lab will not shorten the teeth, but rather make the denture base extremely thin, which can result in fracture of the denture base as well. The next important thing to consider is making implants parallel. With the Glidable Digital Treatment Planning department here, we're able to place implants in perfect parallelism here. I understand that different locator abutments can accommodate a certain degree of divergence as shown in this graph, and standard can accommodate up to 20 degrees, extended up to 40, and then RTX up to 60. It is always a good practice to achieve parallelism between the implants, as the locator abutments and the nylon sleeves will wear as shown here. So not only will you wear out your nylon inserts like I talked about, but your abutments, as you can see on the shown pictures, you're going to see that silver showing through much more quickly if it's not parallel. Next, I want to briefly talk about bar overdentures. And due to its costly lab fee, less and less clinicians are performing this procedure. And you can see many different types of implant bar below, starting with the Hader bar on the left, Dolder bar in the middle, and then there's a CAD/CAM Mills bar on the right. And in addition to already discussed indications, some of the reasons to do implant bar overdentures are if you have a severely resorbed residual ridge that leads to exposed inferior alveolar nerve on top of your mandibular ridge. If you place multiple implants and can't get a jaw, you may want to place an implant bar. And lastly, especially in maxilla, if you have a splinting effect in maxilla to share the occlusal load, this can be helpful in maxilla where the bone quality may be poor. One of the things that I want to stress is that if you were to do fabricate a bar, you must provide a hygiene space below. You can see here how hygiene for both bars, left and right, are less than ideal. However, the left bar has a hygiene space of 1 to 2 millimeters, and there's no hyperplastic tissue creeping up on the bar like on the right. So the case on the right will eventually get perimucositis and leading to potential failure, so something to consider. Now let's talk about an example case. You can see here that the overall prognosis of this patient is compromised due to caries, periodontitis, partial edentulosum, and leading to lack of posterior support. The scans of these upper and lower dentitions were completed, Because it was an immediate denture, we had to make sure the existing incisal edge position was appropriate. Existing dentition was also utilized to determine where the midline is going to be. And here's the immediate denture. Here again, digital treatment planning was completed to place the implants. Remember that the implant placement should be a balance between the final tooth position and available bone. So implant placed in parallel as possible to each other so that we can avoid premature wear of the attachment systems. The teeth were atraumatically extracted here first. We flapped and 3 implants replaced utilizing the surgical guide and cover screws replaced. Then immediate denture was realigned with a co-soft tissue conditioner. This will not only help with the adaptation after the surgery, since we leveled the bone, but the softness can also help with not traumatizing the implants during osseointegration. Here's a 2 weeks post-op. You can see the beautiful healing achieved after 2 weeks. And here's a post CBCT. You can see a good result after healing. And it is important to note that with proper planning, you will obtain good result. We omitted the second stage implant surgery, but healing abutments were replaced. And after proper tissue healing, locator abutments replaced as well. For locator abutment delivery, it is important to know your instruments and tools. A lot of clinicians are familiar with the gold driver, which is third on the left. Many just hand tighten their locator abutments, but it is recommended to torque these in to 30 to 35 Newton centimeter, depending on your implant system. So please find the appropriate instrument and torque the abutments to necessary value, which you can see these are all different tools that you can use to torque your abutments as well. And some of those gold locator tools actually have a hex driver insert on the top. So as the picture shown on the left, you can use your torque wrench with the 0.5 inch hex driver and torque your abutments in. Here's the conventional denture workflow, which is how we fabricated our overdenture. We will not cover the detail, but if you're interested in learning more, we certainly invite you to visit our removable symposium that's coming up in this year. As much as complete denture is not being an exciting treatment for most clinicians, it is a principle. Its principles are something that carries over to a lot of other dental treatments like aesthetic, implant prosthetics. So I highly recommend understanding the denture principle. So with our tooth setup, we verified his midline. Horizontal and anteroposterior occlusal planes were verified. Here, aesthetic is verified, and we felt that the teeth may be a smidge long, so we communicated that with our lab. The vertical dimension is verified here using physiologic rest position. And here's a final denture. The locator wells were created here, and then vent holes are made so that excess material does not flow around the locator as much. And you can see these locator blockout spacer rings, and after placing these white spacer rings, you should not see any gold from the abutment showing. And if you do, or if you're not sure, I recommend you to use additional blockout spacer rings so that you don't lock in your overdenture while picking it up. Quickly move. And those blockout spacer rings are about $1.30 per one. So if you can use these, plastic clear separating film are similar, which cost only about 20 cents each. And these are 4x4, so you can cut them to appropriate size, and you can buy one pack. You'll probably never run out. So you would just place these sheets over the locator abutments and place the metal housing over it, and that's what I do. In terms of picking out the material, there are certain choices here. The easiest one is probably the one on the left. It's called chairside from Zest. It is a dual cure, which will set in 5 minutes. And after it cures, you can easily add additional materials to fill in voids, as it can be light cured. The second option is the conventional cold cure denture acrylic. It is cheap, but it takes about 15 minutes to cure. The last one is a conventional denture rebase material like Tokuyama rebase, which I'm sure a lot of you guys are familiar with. So here you can see there are some voids and access around the metal housings. And after you fill in those voids, you can remove the access. This is the final result for the particular case. The patient was instructed to practice insertion and removal of the new prosthesis with the black processing caps, and later it was switched out to the blue retentive nylon inserts. So this is a chart where the locator nylon inserts are. Left 3 are the standard retention that can be accommodated up to 20, and the right 4 are the extended range that can accommodate up to 40 degrees of divergence. However, I choose my retention inserts. I start from the low retention, so blue or red, and up. And the reason is that high retention inserts will wear down your locator abutments more quickly, leading to earlier replacement of them. So maintenance consideration, we'll quickly go over these. Here's a final result here for this patient. So proper use of locator tools, overdenture occlusion, overdenture reline. So first is the proper use of locator tools. Male removal end has a small tip that will lock into the retention sleeves, allowing you to remove the nylon inserts from the metal housing. And this insert's seating end does not have a lip. So this is the part you use to put the retention inserts into the metal housing. And I'm sure everybody knows the abutment driver that is noted in bold. We talked about it. I've seen a lot of clinicians using the other tools like the end of the perioprobe, and that can potentially damage the retentive elements of the nylon sleeve. So I recommend using the proper tools to prolong the life of them. And even if you can't achieve the bilaterally balanced during excursions here for denture occlusion, you should at least make sure you have a bilateral posterior centric contacts only. And having the anterior contacts at centric will lead to tipping movement of your dentures, which will lead to dislodging. So all maintenance occlusion point adjustment should result in a space between your upper and lower anterior denture teeth. And what do I mean by that? So in centric, this is a very common mistake for denture occlusion. When the patient bites down in centric, the anterior teeth should not occlude. And this is shown on the left picture. And if this overjet clearance is not provided, achieving the bilaterally balanced occlusion will not be possible. But during protrusive, you can see here on the right that the anterior incisors are touching simultaneously with the posterior teeth. And certainly this would be the most ideal situation. Next is the overdenture chairside reline steps. There are a lot of different ways to do it, but whether you reline a prosthesis, first thing is to check the occlusion, adjust it to achieve what we talked about, the bilaterally stable centric occlusion. Then you want to place a blockout spacer ring or tin foils and plastic sheet on your locator abutments. You roughen the surface that you'll be relining, and I usually do not intend to reline surrounding implants. And by mechanically having intimate tissue contact around implant gives you no advantage. So I avoid that altogether so I don't accidentally lock my denture in. Then you apply your reline material to the intaglio surface and place the denture in the mouth and do the border molding movements. Finally, you remove the prostheses and polish and finish. Please note that this becomes increasingly hard if there are multiple locators that are widely distributed. Here's another method for lab reline, and before you plan for this procedure, you want to arrange with your patient and your lab, since the patient will not have the denture while the lab work is being completed. So you want to set an expectation with your patient ahead of time, and also check if your lab can rush your cases back to you. So you start by applying green stick compound applied both anteriorly and posteriorly to maintain the appropriate vertical dimension. And this process is similar to how you border mold, and you will heat the compound and apply the areas to make sure that you temper them in water as well. The metal housings were removed from the denture, and locator well has been widened to accommodate the impression coping. Then you put the locator coping into the mouth, and you do the wash impression with the either rigid impression material, which is PVS or PVE. And if you happen to be using polysulfide impression material normally, once you complete the step, you send this denture. Sorry, I misspoke. And if you happen to be using polysulfide, you cannot do this procedure. So please make sure to use either PVS or PVE to pick up those locator analogs. So here's and then you send it to a lab and they realign for you. So today, in conclusion, we talked about when and why you may want to consider the overdentures, how you want to treatment plan overdentures, and some maintenance considerations. And I know there are a lot of buzz around doing implant-supported complete dentures, but I hope that this presentation was able to highlight that there is still a time and place for overdentures for many dental patients, and it's a good service to them. So thank you.
Thank you, Dr. Lee. Okay, I got a couple questions for you. One of our attendees missed your explanation of implant-assisted versus implant-supported. Can you go back through that and what are the what are the parameters of each one?
Sure, absolutely. Let me share the screen one more time here.
Is implant-assisted is what we used to call implant-retained?
Implant-assisted simply means that all the occlusal forces are shared between your implant and the tissue. So here you can see on the upper left, these are hybrids, our zirconia, Bruxer zirconia hybrids. And certainly when these are fixed into our implants, all the occlusal forces are only transmitted to those 4 implants, though this would be considered implant supported. Here with the bar all fixed over and covering wide array of tissue here, this would also be considered implant supported. But here you can see with the 2 implants located in the anterior portion, occlusal forces will be landing on these posterior ridges. So again, here, the occlusal forces will be shared between the implant locators and the tissue. So this would be implant assisted.
Got it. Got it. And is there a minimum number of implants you need to be implant supported versus being implant assisted?
So you look at it from a biomechanical standpoint. For example, if you were to place 4 implants here and they're widely distributed. So now, even if you have flanges, it is likely that teeth are over these implants and between those implants. So all the occlusal forces are likely to land on these 4 implants. So even though this is an overdenture, this may very well be an implant-supported prosthesis. So if you have 3 implants, 2 on the posterior and 1 in the middle in the anterior, it would still potentially end up being implant-supported. So it is something that you need to take into consideration how you distribute your implants so you don't accidentally load your implants unintended.
Got it. Got it. Okay. And then I think you showed a tool being used for determination of a vertical dimension. What was that tool?
So here, let's see. There are many companies who utilize this tool, so I don't know the exact brand of it, but I can certainly find out for you guys and send it to Dr. Park or Nicole, and who can share that with the attendee. But basically, you will measure from the chin, the menton to the nasolabial fold, and generally speaking, the average facial. The most aesthetic part is that from when you measure this length and measure that from the corner of the mouth to the side of the eye, it should be approximately equal. And this is kind of, instead of using a tongue depressor with marking on it, and this is certainly an easy way to measure as well. So I'll find out the name for you and I'll share that with Nicole in the near future.
Thanks, Dr. Lee. We've got a question here about a digital workflow, like for the reline. Can you talk a little bit about a digital workflow for the reline when you've got a locator overdenture?
Yeah, so even with the digital reline, most likely you will have to pick up your locator again. So if you are to do a digital reline, what I would recommend is that you still need to take out your metal housings you will have to do a conventional denture reline with the whatever wash material of your choice, such as your PVS or PVE, and you send that to a lab and have the denture relined. And after it is relined for the digital, you would have to actually remount the wells and actually attach it again. Currently, we don't have the technology that enables us to automatically put those locator metal housings in digitally.
Okay. Um, yeah, you showed kind of a neat trick to use these little plastic sheets instead of those expensive blockout spacers
Right,
from Zest. Um, can you tell a little more about that? You're just snapping those over the abutment just like you would the
correct.
ring, right?
So instead of having this white ring, before you seat the metal housing, what you do is you cut this small corner of this plastic clear, enough to cover the entire locator area, and put the metal housing over it so that any reline material of your none of your acrylic does not flow underneath your metal housing and get to your abutment.
And you're making a punch like a rubber dam type punch, right?
Oh no, no, it will. This is so thin. This is in microns. It's a very thin material. The metal sleeve will seat no problem.
Oh, I see. So you don't
Yeah,
you don't actually pop
not
the
at all.
okay. So you
Not
just
at all.
well, I'm
Just
glad
cut
I
a
asked.
square. Yeah,
Okay.
cut a square and
Right.
put right over it, and then just put your metal housing right over it.
Okay. And
Mhm.
what material is that again?
This brand was called the Plastic Clear, but there's a lot of material for this. This is generally used when you pack your denture, the conventional analog denture processing material. So Plastic Clear is the name.
Okay. Got it.
Plasti Clear.
Great. Great. I've got a question here about small diameter implants being used for overdenture retention. You know, there's a lot of that being done. Any
Mhm.
any thoughts on that?
Certainly for, if someone's ridge is very, very narrow, and if the options are limited to using those narrow implants with the ball types, they certainly do the job quite well. I don't have any qualms about using those as the locator abutments or the ball attachments. Yeah. What I wouldn't do is loading it, supporting the entire denture on those small implants. That's not something I would do. But if it's just a implant-assisted overdenture with those small diameter implants, no problem.
Great. Great. And any number? I mean, I would imagine you'd use more small diameters than you would of the conventional size implants.
I think two would still be okay, but if you can get around four between the mental framing, that certainly would increase your retention. But I think even two with the small diameter, as long as it's constructed correctly as a denture, then it should be okay.
Great. Great. The case that you showed where you place the implants and then remove the remaining teeth. Do you socket graft those areas that are where an implant isn't necessarily going in at this time? Would you still socket graft those extraction sites?
So if you believe the defect is going to be big enough to cause issue with the future residual ridge, you certainly can. If the defect is extending to the surface of the implant, you certainly want to graft. But if the socket is, if there's a good amount of wall buccally, at least 1 millimeter, you don't have to really graft them because you're not going to gain a whole lot from grafting those intact walled sockets.
Great, great. A couple of questions about the relining procedure. Um, this doctor asked a good question because, as you pointed out, it's sometimes a patient management issue to take the
Right,
patient's overdenture away from them while you
right.
send it to the lab. I mean, is there an in-office lining material that could be used for this?
Certainly. So let's see if I can go back to. So in the lab, if you were to bring it back to the lab, I'm sorry, I didn't share.
I don't think we're sharing right now.
We are
Let me,
not sharing right now.
okay, let me share that
Perfect.
real quick here.
You could see your notes, but it's
So if you are, let's see if you're doing the reline, lab reline in the office, you can certainly use the cold cure acrylic if you're comfortable doing that. However, if you're doing intraorally, chairside, then you can use a Tokuyama rebase. But there are a lot of different companies out there who has their own version, but I'm just familiar with these two brands, so I don't have any relations with them, but I'm just familiar with what I've used before.
Very good. I think you did mention, well, you talked about the vertical space required for locators versus a bar. What is
Yes.
the relationship of the vertical space required for a fixed versus an overdenture?
So fixed, there's a lot of discrepancy between, there are a lot of papers out there that talks about different height requirements. Generally speaking, I learned that the fix would be less, but in reality, over looking at multiple cases and I'm reading a lot of articles, they're about equal. And the reason why they're equal is because of the denture teeth requirements. As we talked about with the Misch paper earlier, a lot of papers don't really consider the tooth height as one of the height requirements. They were saying 3 millimeters more than enough to make overdentures, but that's not really true because even centrals, average length would be 10 millimeters. So how can you say that you can get away with 3 millimeters of a denture height or denture tooth height? So I would say both for fixed and even bar, 15 would be the very comfortable a number. With the fix, with the better material out there, such as zirconia, I think you can get away with a little less, maybe down to 13 or 14.
Got it. Got it. Okay, this is a question from Dr. Palmer, and I love this question because he must have been taught the same way I was taught, and he's asking you, is that third center implant and locator really worth the cost, right? Because the way I was trained is, hey, it's a implant assisted overdenture. It should actually rotate on the two implants. If you put that third, you've really eliminated a lot of that rotation.
Right.
And also typically you put them more toward the front, not like as far distally as the canine. And so I think Dr. Palmer's got the same question in his head that I do. Would you like to comment on that?
So very, very good point. I mean, I think the same way. I think the only time you may want to consider the third one is when you end up placing your lower denture tooth much more anterior to your other two implants. So if your denture teeth are on top of your locator abutments, placed right on top of it, there's a very minimal benefit from placing that third one. But if you feel that your denture teeth are so far up anteriorly that it's going to cause cantilever, and any incising with your anterior teeth is going to tip your back of the denture forward, up, then having the third one can be helpful. But it's a case by case. And I agree that for the majority of the cases, probably you can get away with just doing two.
Right. And I mean, the case you described where you're moving those lower incisors as far anteriorly as you can, that would be some like a class 2 type of patient.
Correct. When somebody's severely class 2 and you're kind of pushing the boundaries a little bit because there's no way the patient's going to be able to incise very well otherwise, then sometimes you kind of cheat a little. I mean, ideally, you want your teeth to be on top of the ridge. But as you understand that if the class 2 is so severe and there's a lot of arch discrepancy between maxilla and mandible, sometimes you have to cheat a little. And in those cases, having the third one could be helpful. But as a rule of thumb, do I always go with 3? I'll probably go with 2 as a rule of thumb. Okay. And then consider 3 if it's needed.
Let me ask you this too, because you've spent some time at the laboratory, you've spent some time teaching, I know. What are some of the biggest mistakes or most common mistakes you see dentists do in doing implant overdentures?
Improper extensions. So more often than not, I see the dentures not really proper extending all the way to the primary support areas. And one of the maxillary overdenture is one of the prostheses that tends to fail more. And one of the reasons is because we're not providing that appropriate tissue support that the implant needs. So in order to kind of protect those implants from failing and overloading, you want to make sure you cover all the primary support bearing areas, and having that proper extension.
Thank you. Thank you.
So
here's another interesting question. What is the maximum VDO that fixed can support? Now, I'm not aware that there is a maximum. I guess it would really only be, based on how much implant support you have, right? So you've got the implant prosthesis ratio there. But let's ask you this: if the VDO is large and there's a lot of intra-arch space, would you prefer to be fixed or removable?
I mean, at a certain point, you have to think about if you even have a long enough driver to screw on your prostheses. I have certain instances where the prosthesis is so tall that we had to get this outrageously long drivers to screw a prosthesis in. I don't think there is a whole lot of what is a maximum VDO, but rather if it's on top of the ridge and implants, not giving a lot of cantilevers in a certain direction, I think that's more important. But if the VDO is very large, more often than not, you're gonna do better with the overdenture that has a flange, because you're gonna get that facial support and aesthetic support that you may not be able to achieve with fixed. But it is, again, that's a blanket statement. So you have to really look at a case and kind of really analyze it appropriately before making that decision.
Got it. You're like the accountant. It depends, right?
It depends, yeah. Usually
depends, right?
it depends, answers a lot of the questions.
Okay. And Dr. Lee, I have to admit, I missed your point about you're talking about the reline, and you mentioned putting compound on the tissue surface, and you said something about maintaining the vertical, but I didn't quite catch what you were saying there.
Yeah. So let's go back here. I'm going to share the screen really quickly. So more often than not, after a patient is wearing their denture for a long period of time, the ridge tends to resorb a little bit, and denture will kind of you'll lose that over vertical dimension over time. So what this paper and clinician did is they put a small amount of compound, both anteriorly and posteriorly, and place it in the mouth and slowly close on the patient, so that we can kind of recreate that space. So this compound is actually a little bit above where these the denture intaglio surface is.
So you're basically trying to restore the original vertical.
Correct. Yes.
Got it. Okay. I see now. Very good. I like that hint. That's a good one. You've had a lot of really practical clinical hints today. I appreciate it very much, Dr. Lee. Thank you so much for joining us today and giving us this lecture. And thank you to our business advisory panel for their great advice. And everybody, please join us next week when our speaker will be Dr. Rebecca Browder, and she'll be talking about some of the tools that she uses for patient exams and communicating treatment plans. She is a digital doctor, so I know she's going to show us some great stuff with digital impressions, as well as AI that she's using in her office. So I'm looking forward to seeing Dr. Browder next week. Thanks, everybody. You take care. Have a great week, and we'll see you next week. Take care. Bye-bye.